Okay, so welcome everybody. This is the seminar on balancing investment for well-being and health equity in the context of COVID with IANPHI and the World Health Organization as well. I'm very pleased that people have joined us. My name is Mark Bellis. I'm the director of the WHO Collaborating Centre on Investment for Health and Wellbeing, which is based in Public Health Wales. We have a fantastic lineup of speakers today addressing a very topical issue in what everybody knows is very unusual times. Sadly, because of unusual times, I'm going to have to leave before the end of the session, but the speakers have kindly agreed to work out the continued chairing between them. So there is an urgent need. I'll just say a few words at the beginning. There is an urgent need to look at both the immediate but the sustainable investment in health and well-being equity in a time of crisis like COVID times. And I think that, essentially that's really what this is about, making sure that those longer term perspectives, when it's so important we bear those in mind, are kept in perspective. Managing the balance, if you like, between the short-term pressures, which we're seeing on emergency care and response, and focus on that, and the longer term perspectives. Of course, there is a primacy, if you like, about tackling the virus, but the pandemic, as we know, will have far longer effects in terms of what we do and the constraints we've put on people, and on a far wider group than just those who are infected. We're already seeing impacts on health and health inequalities in many countries, including Wales, where I come from. And we really need to think now about how we mitigate those issues. COVID, I think, has already shown us the importance of building resilience, of thinking about prevention and equity in advance of pandemics, because it's exposed just how vulnerable some groups are. And when those groups are vulnerable, everybody in society is affected. And arguably, it's also shone a light on our need to examine sustainability on a global basis, because it's actions that think about global health, which may stop things like communities, areas, environments where wild and domestic species are pushed together, where there is easy transmission, poor health standards, which means that viruses can get into the human chain. And then in a world where we casually travel on an international basis spread so quickly. So those elements of sustainability are also critical as well. And there's another element of balance I think we need to think of as well as the immediate, and that's the balance between generations. How much do we want to mortgage, if you like, this generation or future generations or young generations in order to protect, to support acute healthcare and issues which we may be faced with on an immediate basis. And that's no easy thing to think about, and it's not something which is new necessarily, where health consumption has always been at the older, or at least generally in the older years of life. But I think COVID once again has put a light on what is the genuine exchange between that immediate and the long term. It's left us, if you like, with questions about balancing the health, social, economic and environmental aspects of sustainability. And core in there, I think, is the idea of just how much should we be thinking about avoidability of mortality at all costs. Of course, mortality is something we should be avoiding, but what is the cost we are paying sometimes for avoiding mortality, in terms of, if you like, pushing that off into the future for mortality and morbidity we might be facing over a longer time. So we are left with a series of questions. What harms to avoid? What can we mitigate? And what do we have to accept? What do we lose during these COVID times? But on the other hand, what do we want to rebuild better? Even things like what sort of workforce do we want going forward? And even what types of work will be protected, given that one of the things COVID has done has increased the move towards robotics and automation in health and in other areas. But perhaps most of all, and overlying that for this meeting here, it's how do we manage things better so that coming out of this for the years and decades to come, we improve health and we reduce inequalities, and we certainly don't lose the benefits we've made already. So to answer those questions and help with those big issues, we've got a fantastic line of speakers today. And I'm going to pass over now to the first speaker. And I realise at this point that I've mislaid the agenda, which I had in front of me a second ago, which I think is Chris. But if it isn't, someone can please tell me that I've got it wrong. So thank you, and over to you, Chris.
Thanks, Mark. Yeah, you got it right. Just while we put the presentation up for everybody, just really great to have so many people connecting to the session. Today's an ongoing conversation that we want to then continue with you afterwards. So also in the chat, please do let Mark and the rest of us know if you want to continue following up, working on these kind of solutions and issues that we're putting forward. So thanks for the introduction, Mark. Basically, as a kind of an umbrella to this really rich session, which is really focused on the solutions for investing for health within the context of COVID, we really need to start with unraveling who's been affected, what are the pathways by which COVID is impacting on health, well-being and inequities in those, and what does it mean for the kind of priorities and issues we need to be addressing in those solutions. And we have actually in the last year just launched the first ever European Health Equity Status Report, which makes available the kind of health and well-being indicators, the inequities in them across the region. How are they linked to essential conditions that people need to live healthy lives and to prosper? And how are these informed by the kind of previous policy decisions over the last 10 years around where to invest? And I think this is where we need to come back to, because we are where we are because of poor or inadequate investment decisions in the essential conditions that people need to live a healthy life, as well as in health and social systems. Thanks, Tanya. Where should we be investing? What are the impacts we want to have? Life expectancy is an important indicator, and I think in terms of COVID, when we look at the who has been most affected, and we see certain Black and minority ethnic groups, certain social groups being much more exposed and higher mortality, it's really an important indicator and quite shocking. But actually, what we see is that prior to COVID, the health risks for being susceptible to COVID are here. Limiting illness, coronary heart disease, mental health problems, poor self-reported health, indicators that people are not necessarily coping with life and not necessarily resilient. Here we see big differences between the bottom and the top income and education groups across every country in the European region for limiting illness, life satisfaction, mental health, and self-reported health. Twice as much in some cases, and we also see here the gender differences in terms of life satisfaction and mental health between men and women. These are all really important indicators that we need to take stock of if we're looking at tackling inequities arising from COVID. The indicators are fine, but if we don't understand what's driving those indicators, then we don't understand how they're part of the pathways that increase people's risk, or where we then need to intervene for solutions. So what we've been able to do is to actually decompose for the European region, this is generally, what are 5 essential conditions that are statistically significant in explaining those massive differences in people's health and well-being in the European region. We can see that 10% of that is due to inequity in access and quality of health systems. And that also includes accessibility, appropriate, and the quality of care. We know that financial insecurity, 35% is explained by that, but actually, we're not talking about the obvious vision that we have in our head of the most poor. That's bad enough. We're talking about people who are doing 2 or 3 jobs and still can't make ends meet at the end of the month. 29% of those inequities are really due to poor quality housing and underdeveloped living conditions. So When we think about the context of COVID, we're talking here about housing overcrowding, we're talking about quality of sanitation, we're talking about safety and accessibility in neighborhoods. Quite surprisingly, we see that nearly 20% of the inequities are due to lack of trust, sense of control and belonging. And one of the things we know with COVID, it has reduced people's sense of hope, increase their sense of risk, and therefore their ability to see a future. We might see this having a much more impact in the future. And 7% due to lack of decent work and poor working conditions. Now, these are all relevant for COVID, but it's so big that when we're talking to colleagues like yourselves and policymakers and politicians within and outside of the health system, it's very hard to unravel. So what we've been able to do is to unravel the three main pathways through which COVID is impacting on health, contributing to inequities. The first is through direct impact on health. So for example, depending on your age, socioeconomic position where you live, the type of job that you do, you may be more exposed to contracting the virus. And we know that those people with poorer health to begin with are more likely to be in jobs that put them more in contact with the virus in terms of frontline workers, store workers, people doing jobs in terms of delivery, etc., people working in factories. The second pathway is the actual health impact of the containment measures. And here, whilst everybody has been under the containment measures, and most of those have been the same, the impact has been different. So for example, depending on the quality of the housing and sanitation, how that's impact on people's both physical and mental health, where they don't have good housing, good air quality, good sanitation measures. We know that issues in terms of the containment measures have reduced access to services for ongoing treatment, and where they've been available, differences in being able to reach those services, both digitally and in other forms, has also contributed to differential impact on health equity. We also have seen that the containment measures have contributed to family stress, to children being locked out of learning, increasing sense of isolation generally, and increasing in violence and substance misuse. The third pathway, and these are all interrelated, is the kind of effect of being locked out of work, loss of employment, loss of jobs. And whilst there's been massive fiscal packages, completely unprecedented, we know that certain groups in the society, those in informal work, unpaid work, single household families, have not had or got that financial support in sufficient amounts quickly enough to stop them feeling on the edge. So here we see that these three mechanisms tell us something about where we need to be investing to build stronger and more resilient systems and health in the population. What have this contributed to? And this is where I'm probably going to stop with this slide and lead on to the other colleagues, but just to put this on the table now, because we will come back to them. Those who were falling behind before with poor health, who were finding it a struggle to participate in economic and social life for various reasons, their situation has been compounded. So the existing inequities have been deepened where they existed before. We've also seen that there's been new health and economic vulnerabilities arising for people who are locked in, people in care centres, and we see the kind of accumulation and multiplication of different risks that are contributing to such vulnerabilities. We know that there's going to be increased level and concentration of unmet health and social care needs, but they won't be the same in the same countries. So depending on where you've got cluster of deprivation and poor health, the unmet needs there are going to be greater than there will be in other parts of the same country. And we know that there is continuing insecurity in access of essential goods and services such as food, fuel, transport. So these are the current policy challenges, and I'm like to now hand over to Sumina to talk about some of the kind of responses and the investment strategies we need to put in place. Sumina?
Okay, so thank you very much, Chris. So I basically want to take people back to a pre-COVID world, first of all, and talk about the Welsh public health perspective on investment for health and wellbeing in the context of COVID-19. So I'm not sure how much colleagues know, but Wales is a small country. We have a population of just over 3.1 million. And with regards to our history, we had devolution and formation of the National Assembly for Wales approximately 20 years ago. And since then, we've introduced a range of policies that support health and equity. So I've named some of these here, and I just wanted to highlight a few of them, which I think are really key. So we have
Sumina, sorry, I don't think I see your slides. Maybe only me, but I don't see your slides, nor I see you speaking. So maybe you have to set up your system.
Okay, here we go. I hope that's better.
It's fine. Very good. Thank you.
Thank you, Carolyn. Okay, so I've highlighted a few of our policies, which I think are really key to provide a backdrop for Welsh public health. The Wellbeing of Future Generations Act, I think, is very well known across the world, and it translates the Sustainable Development Goals to the Welsh perspective and is, in essence, a public health act. We also have a very specific Public Health Act, which has many components, but interestingly requires organisations to undertake health impact assessments as part of strategic decision making. Very soon, we will also be introducing a socioeconomic duty, which requires organisations to demonstrate how they are working towards better outcomes for those experiencing socioeconomic disadvantage. Now, this provides a really interesting backdrop for our work, and there's a huge amount we could talk about just here. However, I want to frame the conversation more around health and housing, and the reason for this is manifold. So we know that housing is integral to health and wellbeing, and it is one of those essential conditions for wellbeing, which Chris just mentioned. We also know that poor housing is a significant contributor to inequity. So for me, I think one of the key moments for our work in terms of investment in health and wellbeing was a policy window which opened in 2016. And this was the Welsh elections and the opportunity for advocacy when we had new ministers in place. So my colleague Mariana led on the production of a report called Investing in Sustainable Health and Wellbeing for the People of Wales. This report was incredibly influential, and it brought together evidence with regards to where to invest for better health and wellbeing. So there were many areas that were highlighted, one of the key ones being investment in social, economic, and environmental determinants of health. And I've highlighted here some of the key examples which are pertinent to housing. So for me, actually, the key contributing factor to this work was how it influenced my work in the housing field. So as a result of this work, it laid the ground for collaboration with the housing sector, and it meant that we could agree a memorandum of understanding with Housing Association representative body. We could raise awareness amongst NHS bodies about the importance of housing. We could also advocate for the involvement of housing organisations in decision-making bodies where investment decisions were being made. So over the past 4 years, we've had lots of feedback from the housing sector. And one of the key pieces of feedback is that they want more evidence on how to help them make the case for investment in housing. As a result of this, we've produced a series of reports. One of them is looking at how to specifically make the case for investment in housing. But there's also a couple of other reports looking at childhood adversity with regards to housing and also homelessness. And then more recently, we've produced a report looking at how to take a preventative approach to winter wellbeing, and I'll come back to that report shortly. So coming back to the report with regards to investment in housing, this report brought together the impact of housing on health and wellbeing across the life course. What it also did was it highlighted 3 areas for investment where we had evidence-based interventions and where we could also identify information about return on investment. I briefly mentioned this report, but this was looking at taking a public health approach to reducing winter morbidity and mortality and reducing pressures on the health and care system, which happen each winter in Wales. Now, on the face of it, this seems to have not much to do with the housing sector. However, we found that one of the key themes that came through with this piece of work was how important housing was in terms of winter wellbeing. So as evidenced by the contribution cold housing makes to excess winter deaths, and also how housing can be a key solution to improving winter health. So soon after the publication of all these reports and all of our joint working, our landscape was very much transformed by COVID. However, even here, housing continues to be an issue of importance, keeps surfacing. So in July of this year, we produced a report, which was a health impact assessment looking at the staying at home and social distancing policy, i.e. the impacts of lockdown, as we all know it. And as we all know, housing and our view of our homes has been utterly changed by the pandemic. For us, staying at home now is completely affected by the quality of our home, how crowded it is, the access we have to green space, and affordability is also really important for those who are just about getting by. And it's also incredibly important in terms of our ability to adhere to COVID control measures, such as being able to self-isolate. So this report has been incredibly useful to us in highlighting where the key public health issues are going forward as a result of this policy. And we are doing some follow-up work at the moment, looking at housing security and also working from home and agile working. So I know I've focused very much on housing, and our policy work is much, much broader than the housing agenda. So I thought I'd just highlight a few pieces of work which we're currently doing, which are also very much in the investment space. So one of the reports that we're currently producing is looking at basic income in Wales. We're trying to understand the evidence base for this, how applicable it is to the Welsh context, and whether there's any learning that could be transferred to Wales. We're also looking at the potential health and wellbeing, and particularly mental wellbeing impacts of COVID on children and young people. And finally, but certainly not least, we're also thinking about how we invest in our future by addressing other important public health challenges, such as Brexit and climate change. I'd like to hand back to Carolyn, who I believe is taking up the next presentation.
Yes, thanks a lot. Sumini, I try now to share my screen and put on my presentation. There I am, and now the screen. Slideshow. Yes, I think I'm set up here. It's a bit of a challenge, isn't it? With these technologies, microphone, screen, PowerPoint. But I'm delighted to be here. And I would like to thank IANPHI and Public Health Wales and the Region also for being here with all of you for this important topic. Because what we are going to discuss here is how to achieve sustainable investments in health equity and well-being. And this is very important for EuroHealthNet because this is our mission, what we are doing in terms of reducing health inequalities. We are a partnership of national public health institutes also. So many IANPHI members are also member of EuroHealthNet, but also regional health authorities and research institutes. And we are based in Brussels and try to be, let's say, the eyes and ears for our members on what's happening with EU policymaking. And therefore, my presentation is about what's up in the European Union in terms of investment in health now, since we are in the midst of the COVID pandemic. And I will also say a few words about working together and exchanging and learning among the partnership and between national public health institutes. So I first would like to show you 2 quotes from President Ursula von der Leyen, the President of the European Commission. And she stated in her State of the Union speech, which is an annual speech that she did in September, she stated that for her, it's crystal clear we need to build a stronger European health union. And we need to make our new EU for Health program future-proof. And last week, in another speech, she said that all European citizens have the same right to health. And European funding will enable investments in new hospitals, new equipments, and stronger healthcare systems. So this is really, really great. I mean, for the first time, health is high on the agenda as it has been ever before. Von der Leyen also want to increase the mandates of the ECDC, the European Centre for Disease Control, and of EMA, the European Medical Authority. And the Commission is talking about setting up a new agency called the EU BARDA. It's like a biomedical research agency. All great intentions, particularly the idea of a European health union, but we are a bit concerned that the approach is too narrow and more focusing on biomedical sides and not sufficiently on the psychosocial side of tackling this crisis. Also something that we've heard from Chris, her presentation. Because we know that the pandemic and the severity and the prevalence also of the virus and the pandemic is magnified due to the existing inequalities that we see, due to the non-communicable diseases that are out there. We can look at the whole of the pandemic of COVID-19 also as a syndemic, because the disease pattern of COVID-19 is, let's say, interfering with the disease pattern of non-communicable diseases. And we know that about 60 to 70% of the disease burden are non-communicable diseases that are for a large part preventable. So this means that if we look at COVID-19 as a syndemic, we need to also rethink our approach and have a much more broader approach, which means that we need to look into how people are living, how is their housing, as we've heard also from Chris and Sumina, whether they have a job, how is the schooling of the children, are they still able to do physical activity, are they still able to buy healthy food, and so on. So many more factors need to be taken into account if we look at COVID-19 as a syndemic. And this nice figure is from Professor Claire Bambra. And also the issue about the syndemic has been discussed by Richard Horton, for example, in the Lancet. And I find it a useful way to look at the COVID-19 situation we are in now. So we need to reorient our health systems, and we need to put much more central this broad approach and prevention and promotion and equity generally. So let's have a look now at the EU for Health program of the European Union. And this is the program as set out for the next programming period, so 21 to 27. And you can see here the aims are, and the activities mentioned are to deal with cross-border health threats, to strengthen health systems. It mentions prevention and promotion, but merely in the context of older people. It's about medicines and medical devices, cancer, AMR, vaccination, rare diseases, global health threats. and so on. So it's really great, and it's important that we tackle these things. And what is really good is that the size of this new budget is much larger than it was of the program before, 4 times the size of the previous program. Even though the Commission asked for 10 billion euros, but the Council decided that 1.9 billion, they decided this week actually is high enough. But still, it's a large budget, which is very good. But again, it demonstrates a little bit the narrow approach and not the approach that the syndemic requires us to take, or also what we've seen in Chris her presentation. And even this budget, 1.9 billion, even though it's large, it's not big enough by far to tackle with all of these issues, because there is a huge gap. We are facing a huge investment gap in the social sector, and in particular in the social sector, including education, housing, health, and social services. The gap is estimated by the European Commission on 192 billion per year in the European Union, in all member state countries. And if you zoom in on health, the health investment gap has increased from 20 to 70 billion per year, around 0.6% of the EU GDP. Generally, when we compare to the situation before the previous crisis in 2008, they estimate that the public sector investment is 20% lower than it was at that time, while we know that the demand has clearly increased. So if we want to address this, and if we want to address health and try to get sustainable investments in health and well-being, I suggest that we frame our health strategies into a broader context, like achieving the economy of well-being. And the economy of well-being is a very interesting concept that was launched by the Finnish presidency last year. And this is an economy that is accessible to all. It's there across all social divides, across political spectrum. It puts people central. It is an economy that respects planetary boundaries. So really a broad concept that we can use to make the case and for our advocacy if we want to ask for better investments in these areas. The evidence for the need to change is overwhelming with COVID, with inequalities, but also the climate crisis that is looming there. We are in the midst of the climate crisis, which will be even more severe than COVID-19. So we need not to go back to business as usual. That's not an option. We need to rethink and renew ourselves. And I would argue that national public health institutes also need to go along with the change, try to step out of the narrow health silos that may be there. And I really see this as a call for action for us all. And opportunities are out there in terms of money and investments, because if we look at the next long-term budget for the EU, in the coming period from 2021 to 2027, the MFF, it's called as the multi-financial framework. Then there are many opportunities for seeking investments for health and well-being. It's all linked to the European semester. And I don't have the time to go in detail, which I will not, just very brief. The European semester is a very broad, high-level policy tool for reforms, like health reforms in countries. And it's linked to funding, to all of the funding programs. And the Recovery and Resilience Facility is the largest ever fund now that has emerged due to COVID, with 312 billion in grants and another 360 billion in loans that can be used for health reforms and social reforms and other reforms. The European semester is also going to be linked to other funds like the Regional Development and Cohesion Fund, like European Social Fund, ESF+, is over 100 billion euros. And it has various conditionalities, like at least 25% of that need to be allocated to social inclusion, at least 5% for the most deprived, 5% for children in need, 10% for young people not in education or unemployment. So really an interesting fund to use if you want to work on reducing health inequalities and investing in health and well-being. Just Transition Fund is linked to the Green Deal and trying to get the green transition and helping out people that may suffer because of that. And Horizon Europe is clearly the research funds. And Invest EU is an interesting one because for the next period, they will have a separate window to tackle inequalities, social issues, and they provide guarantees for loans and a lot of money also to access there. So health and well-being are on these agendas if you look at it from a broader context, and it is our responsibility to engage with these processes. So in summary, we have seen now an unprecedented investment in health, and we want to see a systemic change, and we also want to see sustainable investments in health and well-being. We don't want the money to disappear, once COVID is out of the way, and also clearly with the future potential recession, we want to see the sustainable investments. So this means that we need to build our partnerships and work towards an economy of well-being, get engaged with policymakers that decide on budgets, take the lead. I think national institutes of public health can take stronger the lead in the countries and with others build on international cooperation and boost capacities of your staff to understand these dynamics and how to access the funding streams and finance instruments. Eurosnet is developing a tool, an e-guide on finance instruments, and my colleague Alison will later during this seminar go more into detail what other things there are, finance instruments are that you can take note of. For now, this is what I had wanted to discuss with you. And what we are now going to do is have our short debate, and I'm really keen to hear from you what your reflections are on the presentations that you've heard right now. So I'm now going to stop sharing my screen, and I'm going to look at all of your attendees. And I would like to say that you can raise your hand if you would like to make a statement, because we would like to hear from you how you look into the current investments made in health due to COVID, how we can increase or ensure investments in more the psychosocial preparedness and psychosocial and other factors related to health, and ideally in sustainable ways. We will be able to make you visible. So we will be able to show your video and also your microphone so we can actually see you. If you are too shy to speak up, then you can also add your questions or comments in the chat. And in that case, I will ask my co-panelists to reflect on your questions. But we thought that you may actually want to contribute to the debate and to give a first reflection of your situation, or maybe even share with us your or maybe the difficulties or your concerns about monies that and investments for prevention and for health promotion and for tackling inequalities. Or maybe you have experience with accessing European Union funds that you would want to share with us. Meanwhile, I don't see any hands raised, but it can be my technical ignorance. that on my screen, I see all the many names. There are 38 of you there. I just don't see any hands raised. But it may be that you do not want to say anything. In that case, and if there is also no question, then you know what? What may be best is that we go to the next set of presentations. We have 3 nice presentations for you more. And meanwhile, you can think about, okay, the questions you would want to ask, or the issues you would want to raise yourself or share with us, which we would actually like to hear. So in that case, I would like to give the floor to the next speaker, who is Tatjana. So Tatjana Buzeti from the region Venice. Yes, Tatjana, if I can ask you to present. Yes. You will need to unmute also your microphone, Tatjana.
Okay. Hello from my side. Do you hear me now?
Yes, all fine. Yeah.
Okay, thank you. Thanks a lot. So our second part looks a little bit more into the solutions that are arising, and in particular into collaboration and co-production of them. Therefore, I would like to start with the slide that's actually putting forward the solution platform, the health equity solution platform that was called for by last year high-level conference that was organized by WHO and Slovene government in Ljubljana, and that was paving the way also to a health equity resolution adopted just 2 months later than during the regional committee, and that all the member states of European region endorsed with the present UN partners and NGOs. And I think that gives us all quite a big step forward in terms of having some legitimacy to put equity really strongly into the forefront, and actually that calls also back to all of us on our commitments, because there are quite clear commitments on the WHO side, what we are going to do and deliver. And there are also commitments on the member state side that we have to move much faster from recognizing the problem or challenge of existing and rising inequities in European region. And actually that this is the only SDG where European region made a negative progress, how it was shown in the report of European Commission last year. So definitely these are some strong initiatives, and there are some strong inputs. Nevertheless, looking into the COVID reality, we see how drastically important they are in order to deliver better results and to address unexpected consequences of underlying conditions that we often call it social determinants, essential conditions, factors that are influencing in the end health outcomes, beside the health care and the health system contributing also importantly to it. But this is the area where we are touching also upon other policies, other players in the community, in the sub-regional, regional levels, and on the national and global levels. And within Health Equity Status Report, we clearly put 4 questions forward around which we want to build solutions. So the first one, who is being left behind? It's a lot about monitoring and how we are capturing that. So what is holding people back? That already Chris showed in the graph. So it's not enough to identify only who is left behind, but also what is holding these people and why they are left behind. How can we close the gaps? And here we are now very much entering the solution fora. And why does it matter? So if it doesn't matter, not much is done, isn't it? And sometimes in public health, at least I have 20 years of experience, that often we feel like, but it really doesn't matter to many of our stakeholders around the table. If we frame it too narrowly, if we sometimes go too specifically, and if we are not open up for the broader discussion about well-being, about closing the gap. And on the left side now, therefore, we started to develop some tools, actions, in order how we can actually practically build a solution platform. And we can build it only with you. WHO cannot do it on its own. What we did put in is the online knowledge hub. I will share the link to it on the next page, and where are all the data that are available up to date that actually were the basis for regional health equity status report and for the country profiles that you can access. Compounding and in supporting to that, there is a list of interactive tools that are accessible on WHO website that are talking about drivers of health equity, such as transparency, participation, engagement. And currently we have already 3 nations, or let's say regions, even more, doing national HESRIs, or National Health Equity Status Report. Wales being one, Slovenia, Italy, and we are starting now with Netherlands in the region of Utrecht. And there are already new learnings just in these few months, taking up from the regional level, looking into specificities and taking into account also COVID reality, because a lot of this data now is heavily influenced by it. And once we are looking into that simultaneously, these countries started to create a kind of innovation site for monitoring of health inequities, but monitoring also of the progress of policies that are developed and implemented in these areas. So this is another very important part, how we capture the learnings in different countries, in different communities, to faster advance the agenda and actions also in other countries, member states, regions, cities that are ready to take up and maybe at this point don't have enough resources, don't have enough knowledge. And therefore partnership and alliances are key. Regional partnerships and alliances that can influence also regional global agenda, but as well as sub-regional, where countries and can learn peer-to-peer, where countries where have much similar systems or policy orientation can work together in order to implement commitments. And least but not last, the communication and advocacy strategy, and also tools that we develop jointly and make a strong argument that help us then also to stream the investments that are actually possible. And we see that there are quite some funds available which we are not reaching to them, not in a significant way. And thanks to Caroline, it was a very nice overview what is available in the next financial perspective within the European Commission framework, but there are also opportunities within the UN frameworks and development funds that are in particular more on disposal for the countries Eastern and in already towards Central Asia. Yeah. And if we look into the area of monitoring that I touched in the beginning, on the left side, you have the online health equity dataset platform that I encourage you, please go into it, use the data and make the cases. As example, for example, we are often using it when we are getting country requests to make certain proposals, or when we are trying to see where we are in certain sub-region of the region. And actually, this is a nice starting or baseline where you can see where you are with the health inequities in your country, what are the data that's shown pre-COVID time. And of course, also WHO, with all the emergency response, didn't forget the part of looking into the assessment of social and economic impacts of COVID. And on the right side, you see the front page of a front-coming publication that will be published very soon. It's not yet available, but I think it will be in the 2-3 weeks. Chris is confirming. And it has been already tested in North Macedonia in the context of preparing their national recovery plan. So this is a tool which at the present is still in a kind of Excel sheet format, but we are already developing online, more user-friendly version that can help analysts, but also the policymakers to look into inequities in all the 5 essential condition areas, but also to look for the groups that are particularly facing vulnerable situations and where we need to really pay attention that this vulnerability is not increased. And if we practically, for example, look what these kind of tools can help us do. So this is example of a country over 3 million that, like many European countries, is facing challenge in mental health. And this is a very relevant example for COVID reality, because we know that containment measures, but also facing with social and economic consequences, will be or already are a big anxiety and mental health issue for big parts of the population. So if we look in this example, we see the recognition was there. So the government decided to take the actions and to also look into the inequity with reducing the income inequality with taxation benefits. However, on the other side, there were some counteracting measures and situations. So to receive social protection benefit, with the change of the policy, there were delays. So basically the bottom 20% didn't benefit as quickly from this reduction of the taxation. And it was a very negative impact on that. Then, of course, increased insecurity in employment was the biggest in the lowest 20% of the population. And reduced investments in community amenities, they were in most cases in the most deprived areas. And that on top of the reality that for the whole of the population, delays in access in affordability of health practitioners and services, of course, hit the bottom 20% most. So even we see one measure looking specifically into equity and in the bottom 20%, doesn't solve the problem. So the message from our side, in particular within history platform of tools, is you have to work with the basket of measures and policies in order to see the progress. And often we either ignore or are not aware or forget this, and then we are wondering why, with all the good universal measures that actually we are introducing, we are not having the expected results and outcomes. And that's the frustration of public health in the discussion that we are having. We are sometimes not able, and sometimes also there are barriers to look into the whole basket of the policies that actually are needed. And I think that's the key added value of the health equity status report methodology that's in this third type of data, looking into the policy progress, and it's listing different policies against each other in order to see how the gaps can be closed. And of course, every country has different specifics and might have different package, but the issue, the message is it needs a package, not a single policy. And to go to the driver of equity that's linked to engagement and participation, we started during this year in response to COVID with two big initiatives, one in collaboration with Nobody Left Outside initiative and platform of 10 European-wide platforms of marginalized groups that are really putting together their capacities and resources in order to raise the visibility of issue and challenges around the access to healthcare services for marginalized groups. And this in COVID reality became even more visible and evident. And it was actually very much debated during last week, that No One Left Outside week together organized with the Gastein Forum and many different speakers, including also our RD Hans Kluge and the commissioner. All recognizing that actually we have blind spots and that we are missing a lot of populations in response and even more in recovery planning if we are not engaging them already into the mapping of the vulnerabilities, into design of needs, and into the designs of responses and solutions. So the both initiatives here are actually partnering up with us to bring exactly that, to bring the real life and lived experience into the policy making and to help us capture that with new innovative approaches. And another initiative is a joint project with Lancaster University Health Foundation and community-based organizations that are now jointly developing platform of community bloggers and a website where they will write about the experiences during the COVID, but it reaches beyond that also in order to really bring the global voices of social justice into policy making. To finish with the communication and advocacy, I would just like to put two messages. On one side, how do we use the public opinions? How do we use the public polls within our countries and region-wide? If we look at them, we see that 84% of all Europeans believe that the reducing health inequities should be the top priority of government agenda. So every politician is most sensitive to the voters' opinion. So how do we make the case out of that? On the other side, we know that electoral cycle is 4 years. It's very clear message from history that we can do the change in 4 years if we invest in the core policies around essential conditions. And that with that, we can save many lives, depending of the size, of course. But I think when you start talking numbers, because sometimes the other side doesn't hear you as long as you don't quantify it. We know that in 4 million countries, we can save 15,000 lives. When we have 40 millions, we can save 150,000. And when we have 80 million country, we can save 300,000. It's not that we put the money to the life, it's beyond that, but it's important sometimes to quantify what do we speak about it and how we develop our communication and advocacy. And these tools are enabling and helping us also to do that. And let me stop here. That are some examples. You can find much more on the site if you look into Health Equity Status Report Initiative, and there are all the tools on the website. But we are happy also to follow up with you individually when we are looking into different solutions and the groups within the solution platform you would be interested to participate or to contribute to. Thank you very much. And I would like to give the floor next to Mariana Dyakova to complement this with a country example and take up in the case of Wales. Over to you, Mariana.
Thank you very much, Tatjana. Thank you. It's a pleasure, and thank you very much to IANPHI for organizing this really important webinar. We did have plans actually that this will be a session during the meeting in March, which didn't happen due to the COVID pandemic. So I'm pleased that we are able now to share some of the developments and experiences related to sustainable investment in well-being and health equity, but also reflect how the COVID pandemic has sort of influenced and what are the potentially developments in relation to COVID. So let me share my screen as well. And I hope so, right? Hopefully this should be visible to all. Right, so I think this should be visible to all now, hopefully. I can see also, I'm quite glad to see 2 questions into the chat. So Caroline, one question is for you, but one is to Sumina, and it's very much around how do we do advocacy, and Tatjana mentioned exactly the last slide, which is a really nice transition to what of course, I would like to share from our experience from Public Health Wales and Wales as a whole. So hopefully there are a few things I will mention just, and then I'm happy, of course, to follow up after the meeting. If you want to know more, you can look at the tools also online. So of course, we don't have enough time to go into detail of all of these. So hopefully this will be helpful, and I'll just mention again a couple of hints or maybe suggestions and tips of how to sort of promote advocates and politicians and government. So the topics we've been discussing and are prioritized, and investment is prioritized. So as a WHO collaborating center for investment for health and well-being, we were designated in 2018, and we have been doing quite a lot of work together with the WHO European Office for Investment for Health and Development in Venice, where obviously Chris and Tatjana have been presenting, and also with EuroHealthNet we've been working closely, and of course the next presentation will follow up again with some tools related to investment, which do link nicely with what I'm going to mention. So we started, as my colleague Sumina outlined, with the Making a Difference, which we call it. I mean, it was an evidence synthesis report, but it was really an advocacy report, which gave, it was the presentation largely is important, mentioning the numbers, making the case for investing, showing the return on investment, showing the costs for the NHS, for the society, for the wider economy, not only in terms of health and death and illness, which is of course important for us as public health professionals, but it doesn't necessarily ring a bell to people who hold budget holders, and well, it does ring a bell to politicians, but then it's always nice to support it with figures. So Making a Difference did exactly this. We have produced 8 infographics related to different priority areas, such as health inequalities, mental health and well-being, obesity, and diet, smoking, alcohol abuse, and violence prevention, and so on. This is all online. And then following from this, we developed a WHO health evidence synthesis, or health evidence network report on investment for health and well-being, doing the same on a European level. And then the next report, which followed in Wales, was actually to align, and this is one way of doing advocacy, to align these numbers and to align the evidence already in these reports to priorities in Wales and organizations in Wales. So in the third report, you see driving prosperity for all through investing for health and well-being. We align what we've already found into the evidence to our Prosperity for All national strategy for our well-being of future generations act, which, as Sumina mentioned, we do have in Wales a quite favourable legislation and policy environment following the Sustainable Development Agenda. So we are lucky, and then we have quite a supportive government as well. However, they do need, again, the data and the numbers aligned. So we had in this document, we have essentially said, oh, this is what needs to be done by government. This is on national, local level. This is what needs to be done by NHS, Public Health Wales in particular, and this is what needs to be done by wider stakeholders, so the third sector or private sector, for example. So this all, of course, was in parallel, and more recently, we have worked together with the WHO Venice office around the Health Equity Status Report Initiative, and I'll mention, of course, the work we've been doing around the Welsh Health Equity Status Report Initiative, which is one of the pilots currently in progress. An important practical guide we developed and published last year before COVID, and which gives you these practical tips, which might be helpful to progress the work with policymakers and politicians, is how to make the case for sustainable investment in well-being and health equity. So this is an interactive online practical guide, and is a small executive summary which we published as well. There is a live link in the document. So in this guide, we go through 4 phases, describing exactly how we can be more effective into our sort of advocacy efforts. So it starts from project scoping and planning, working together with our stakeholders, working together with the policymakers and with the government, so they're informed from the beginning and they can feed in. Phase 2 is evidence gathering and synthesis, which is, of course, based on the classic principles of evidence mobilization and synthesis and translation. And then we have the third phase, is dissemination and communication, which is largely translation into it is critical for translation into policy and practice. And it is important to use numbers, as already mentioned by Tatjana. It is also important to use visuals and stories. So infographics was a key element into all of ours, and has actually been for the last probably 3-4 years now. All of our reports have been again visualized through infographics, which makes it again quite easier and quick for people to understand and use as well. And then the fourth is, of course, monitoring. The fourth phase is monitoring evaluation. So I'm not going to spend more time on this because, again, we don't have enough time, but this might provide some resources as well. So again, the guide is not that much in-depth, but provides useful resources and tips and structures and frameworks in which, through which you can sort of accelerate the advocacy process. Quite an important, again, approach, if you want, or framework we started using again before COVID, and we are getting back to it, is the evidencing the social and economic value of public health services and interventions based on a social value approach. So social value is something which was coined by now a collaboration called Social Value UK, And the social value concept is a holistic concept of value which incorporates social, economic, and environmental outcomes and impacts from different interventions. It has been applied largely in the private sector, but we are now trying to apply it in the public health within our public health programs, and trying to show or to monetize again in monetary terms what is not only the return on investment, which is only the financial value of services, and sometimes the financial value, the financial return on investment might be not very much from population level programs, from health promotion campaigns. However, the social value, which is really what matters to our stakeholders, to our target groups, is what we would like really to show, and sometimes it's useful to monetize this. So it's very much linked to the value-based healthcare approach. So we sort of call it a value-based public health. So again, if you want to learn more, we're welcome to discuss this later on. To link back to what Tatjana and Chris were talking about, so we are currently developing, we started and we sort of established the Welsh Health Equity Status Report Initiative before COVID started. We parked it for a bit, but now it's coming back in the context of COVID and the importance of the wider impacts of COVID, particularly exacerbating health inequalities, increasing non-communicable diseases, having impact on young people, in particular related to unemployment, mental well-being, vulnerability, vulnerable groups, and so on. So we are currently building a digital solutions platform, which is very much again what a national Welsh pilot and an application of the European Solutions Health Equity Solutions platform, which will incorporate the evidence, combination of policy analysis and data analysis and health economics analysis, but also different resources. So trying to link really the different aspects of the data, of the existing policy context, of health economics, evaluations and modeling, but also linking with international resources. So we are currently looking into developing a COVID also aspect into that, and a COVID report, which I think is into the next slide. So particularly in terms of COVID, as it was mentioned, COVID is recognized as a syndemic with its wider and than longer term, mid to longer term impacts, in addition to the acute health protection pressures. So we're doing a number of activities supporting the public health response in Wales. So one of these is the International Horizon Scanning. We do health impact assessments, which Sumina mentioned. There is a national public engagement survey, a dashboard of broader health and wellbeing indicators, and balance prevention unit, also dashboard as well. And then we are also aligning the Westry solutions platform and reports, and we're doing also some economic modeling related to that. As a tool, the International Horizon Scanning reports we publish every 2 weeks. We're sending them to IANPHI Secretariat. So if you're interested, they are published online and available. There is a live link as well. So they are based on empirical emerging, empirical learning and emerging evidence from countries as they progress and address and respond to the COVID pandemic. So, for example, particularly in the context of investment, we have been looking into response and recovery policies and wider socioeconomic and equity impacts. So providing this evidence from emerging reports, and again, countries, the different government and national, local government initiatives and help, for example, related to businesses and unemployment and young people and so on. This is again mentioning the Westry and the digital platform. I'm not going to go into detail, but we are planning to publish a report around COVID and inequalities in the framework of Westry in the winter, in December. and we are integrating the COVID, again, data and modeling into our solutions platform. Just an example around the modeling, our health economist, and it's an important, again, element of building a health economics capacity as part of the public health institute's workforce or capacity. Ours is currently quite small, so we have only one health economist, unfortunately. So maybe other institutes will have a bit better. Well, we're trying to build this. I think we will be increasing this hopefully soon. So we've just published a couple of weeks ago a modeling a projection around the impact of unemployment on the long-standing illness and chronic conditions in Wales. So largely what is expected is a rise of unemployment almost double from 3.56% currently to 7%. And then with these, we expect also a rise in long-standing illnesses and chronic conditions, particularly metabolic and endocrine. So this is, of course, having an impact on the use of health services. And the next report will be also on health service use in Wales projection. So this is all from me, and hopefully this was useful. I'll pass the floor to my colleague, to Alison from EuroHealthNet, to follow up with more useful tools. Well, one in particular I know about the finance, but yeah, if you want to show, of course, other work of EuroHealthNet. Thank you, and over to you, Alison.
Thank you so much. It's really a pleasure to be here with all of you today. I'm just opening the presentation. So yes, as Caroline said, thanks so much to IANPHI and to our colleagues at WHO Venice, to our colleagues in Wales. It's really a pleasure to be a part of this session today. And I won't take too much time. I know we're coming to the end, so I'll try to be quite brief in my presentation. I do want to talk to you about a tool, an e-guide, that I think some of you are familiar with, that EuroHealthNet has been developing over the last year or so. And this follows on some work that we've been doing more generally around innovative financing for health promoting services, starting really, I would say, around 2018, a conference on this topic, then also building some alliances with other European networks here in Brussels, working in other areas of the social sector, for instance, in housing and education, and seeing what kinds of activities they're doing to also support innovative financing in their work. And then in how we could potentially work together to use a tool such as InvestEU to support more multi-sectoral investment and collaboration. So I want to first preface the presentation by saying that we recognize that budgeting is first and foremost a responsibility of governments, of national governments in health. And in suggesting these different innovative financing options, we're not in any way advocating that governments should reduce or remove that responsibility from themselves. We see this as an opportunity to enhance on what governments can do, because we all recognize how limited national resources are. And even the really tremendous resources that Caroline was describing from the EU, those alone won't be sufficient either to fill the gaps that we're seeing in health infrastructure investment or in health investment. And so what we'd like to do with this tool is think a little bit outside the box. What are some other ways that we can bring in new investors or bring in new approaches to financing health promoting services? So to that point, the central objectives of this e-guide are to illustrate different ways that resources can be mobilized for health promoting services. And even broader than that, to think about what are some ways that we can strengthen health promotion and disease prevention services. How do we define what is a health promoting service? And I think this comes very much to the point that Sumina was making around housing and how critical, and the points that Chris was making, 10% was related directly to access and quality of health. And there are so many underlying determinants. So how can we link in our health promotion work with some of these other fields? So I will share the URL to the guide in the chat as soon as I wrap up here. But in order to navigate the e-guide, there are two main ways that we see you can do it. The first would be a navigation bar across the top of the guide, which shows the different topics. And here, as an illustration, I've highlighted the social outcomes contracting section, that topic on the website. And you can see that we provide a definition of what social outcomes contracting is. And if you were on the page and were to scroll down, you would see more resources available, as well as links to relevant case studies on social outcomes contracting. There you are. The other primary way that you can navigate through the e-guide would be using the bar that you can see on the right side of the screen. And that's also the same on the website. It's on the right side. And you can find there information not only about some of these innovative tools, but also about EU funds, InvestEU. And of course, that information is still being updated because we recognize that the negotiations are still ongoing here in Brussels, and we don't have the final figures at hand yet. But you can also see quality criteria. I'm just opening the chat to make sure I see a lot of chat. I want to ensure that you can hear me. Well, I can't open the chat right now, but I'll just continue then. Hopefully there's no problem with my sound.
No, everything fine.
Okay, great. So then, yes, so you can also see on this sidebar quality criteria that an investor may want to keep in mind when looking at types of projects that could be funded in health promoting services and so on. And I think the most important here would be the case studies themselves. You can access directly the different case studies that we've collected to date on the e-guide. And we'd like to also encourage you to see this tool as a living tool that's going to be continuously updated. If you have case studies from your own country or your own region, activities that you think would be relevant to showcase in a guide like this, we would really encourage you to share that information with us. So this, again, is something that we'll be continuously updating, both the case studies we have on the site and adding new case studies over time. And you can see here, the case studies are coming from a lot of different places across Europe, many from the UK, as it is an influencer, I think we can say, as Mariana said, but also from Sweden. We have a couple from Canada. So really, we're trying to draw from a lot of different resources. So I want to go through 3 different case studies during the time we have now. The first would be around social impact bonds. And so these bonds are a type of social impact investing, which in short, you could call payment by results. But really what it is socially minded investors coming together to provide upfront capital to finance a particular type of service or project. And then the payments or returns received by those investors are only made if the program meets the predefined social or health outcomes that were agreed upon at the start. So social impact bonds are one type, social outcomes contracting are another. And here the example we have is about reducing loneliness in the UK. And so Reconnections is the name of a program connecting older persons with volunteers or caseworkers to help them re-engage with interests in social relationships, because we all know the links between loneliness and health and the growing evidence in that field. So the costs are around £750 to £800 per participant per year. And investors in this case provided an upfront capital of £650,000. And the first 2 years as the program was being established, it was loss-making. But as the program and the impact of the program has grown, they are now able to make payments, make returns to those investors. And over 15 years, the program is expected to deliver more than £3 million worth of savings to the public sector. Another big area where we think it's important to look at examples is joint budgeting. And this really comes to looking beyond the health sector. And I think that this graphic demonstrates it quite clearly. We may have a program that we want to fund, but our individual resources as the health sector wouldn't be sufficient to fund the program. However, if we were to link up with, for instance, education or with housing, we may find that the willingness to pay of those 3 sectors working together would be sufficient to fund the program. And you can find some different examples of joint budgeting on the e-guide site as well. And I think all of us can agree that spending in healthcare could be more efficient than it is now. So looking at joint budgeting is one example, and another would be around disinvestment or investment. And so looking at how we can reallocate resources or improve our use of existing assets. And so the example we've given here also happens to come out of the UK from Public Health England. It's the prioritization framework. So this is a priority setting tool for public health investment decisions, which can be used by local authorities to help them make decisions about budget allocations. And it's really meant to be a very structured and transparent process more than anything. And it consists of 8 essential steps, such as defining criteria or gathering evidence. And these can be discussed over a series of workshops. And the idea is that the workshops would bring together all of the relevant stakeholders from the different health programs under consideration. And the final outcome of this, using this framework, would be a recommendation to either increase, decrease, or maintain the same amount of funding in the program that's being considered. And the local authorities can take this recommendation and apply it or not apply it. It's up to them. But really, when we spoke to our colleagues about this case study, they said the value of this was in the process of getting public health professionals to sit down together from different programs and to think about their priorities jointly. So again, another area where there are many case studies, but just one to show you for now. And so what's the final message that I would want you to take away from this? I think the first would be, please feel free to visit the e-guide and come to us with any questions you may have about it or how you can use it in your work. Generally, to think about how we can explore new sources of finance for health promoting services, and more broadly, how we can employ new models of problem solving in our own work. Again, if you have any examples you would want to share with the e-guide, we're very happy to hear from you. And one final plug to say that tomorrow morning at 11 o'clock CET, EuroHealthNet is coincidentally having a webinar on financing. So we'll be talking more about this e-guide. We'll have a specific presentation from one of our case studies in Sweden on social outcomes contracting. And we'll also be looking a little bit more in depth at some of the MFF negotiations that Caroline was talking about in her earlier presentation. So thank you very much.
Thanks a lot, Alison. I would like to abuse this place to just add that EuroHealthNet will also develop a briefing on the MFF, on the multi-financial framework, to give you an overview of the funds in the next periods from the EU. Well, we have heard many tools from all of you. I think it was a really rich set of presentations, many initiatives, tools to use. I look forward for the solution platform that was proposed by WHO, but also IANPHI does a lot, EuroHealthNet does a lot, Public Health Wales, a lot of activities, and I hope this has been a really rich and resourceful webinar for all of you. Before I close, because unfortunately we will no longer have time for discussions and debate, but before I close, I would like to give the floor maybe to Chris, as you started with your first presentation and you may want to give some further reflections from your side. Chris.
Thanks, Caroline, and thanks to all the presenters and also for the chat. I mean, just looking through the chat, there's a thread through there that says really this is a wealth of both new and rich information, investment case tools, what are investment frameworks. But the question is, how do we use it to actually make a difference? And I think that we would say there are 4 ways that what we've presented today, you could work with us and also use yourselves to make the investment case that will make a difference to people's lives. I think the first is using it to show that action to reduce inequalities and investments made in certain types of policies through different types of frameworks with other partners or directly through health can be done and can actually make a difference to real lives. And so what we're saying is the investment tools and methods bring people and real lives into the decision makers and the policy makers' minds. Secondly, can be used to say, what are the consequences if we don't reduce inequalities and build well-being? And that, for example, let's think about it now. We're likely to have mass unemployment event coming up from COVID. That is going to have a huge impact on mental health. It will also have a massive impact in terms of overwhelming demand on health and social services. So the consequences for not acting now and investing in the right way will have undesirable consequences for policymakers across government as well as for people in society. Thirdly, using those tools to show that by investing to reduce inequalities, it also is part of the solution to solve other problems such as resilient communities, families, social cohesion, to ensure that territorial cohesion between different regions and cities and within municipalities is maintained. So I think that these would be the three things. And then the last is using it to show that there is a real demand within society amongst voters across political parties with other partners for improving health and well-being and reducing inequalities. So that's how I would kind of maybe sum up my reflections from what I've heard and the chat. Thanks, Caroline. Back to you.
Fantastic, Chris. That's a really nice wrap-up of this session. So I would like to thank you and Tatjana from the WHO Venice office. I would like to thank Mariana and Sumina from Public Health Wales, and Alison, my colleague from EuroHealthNet, and last but not least, the organizers from IANPHI, and particularly Louise Rigal, who has been coordinating all this so very well. And to all of you, the audience and the attendees, for your interest and your commitment to this session. Very nice. And I would like to say thank you and hope to stay in touch and see you next time. Thank you.
Thank you to you, Caroline, as well.
Bye-bye.
Bye-bye.
Bye-bye. Bye.